Next speaker is Dr. Anuradha Raj. She is professor and head of AIMS Bathinda. She is speaking on small incision cataract surgery combined with the trabeculectomy, a single site approach.
Good morning, everyone. First of all, I want to say thanks to AIOS and Dr. Karamjit for giving me the opportunity. So, with all the insights into SICS in difficult cases, tunnels, and capsule access, I'll be skipping my videos and I'll be concentrating on only the steps which are combined. Thank you. So the topic of discussion is SICS combined with and that trabeculectomy. So various indications where we can combine both procedures. At SIRS at Morgagnian cataract with raised IOP, intumescent cataract, calcified anterior capsule, corneal opacities, small pupil, and grade 5 and Niagara cataract. So it's not running. So another thing for trabeculectomy, when IOP is very high and it is getting uncontrolled despite maximum anti-glaucoma therapy, angle closure glaucoma where interior chamber is already shallow, side effects of the drugs are there and patient is having cataract also, advanced glaucomatous damage is there, progression is there, and target pressure is not getting achieved and non-compliance with the drugs. So when we can combine that coexisting cataract glaucoma, pseudoexfoliation, phacomorphic, and angle closure. So these kind of anterior segment we can get with anterior chamber shallow, corneal edema, raised IOP with the mid dilated fixed pupil, and such kind of pupillary roughs. So various challenges are in trabeculectomy with the SICS are shallow anterior chamber, hypotony if previous trab is there, floppy iris, small pupil, and synechial changes. Preoperative considerations are visual loss because these patients have some kind of compromised vision also. Slit lamp examination for pupillary rough, it is very important. Anterior chamber, because we have to work in anterior chamber, pseudoexfoliations. Then fundus for glaucomatous optic atrophy and macular pathology if it is coexisting. And some most important is conjunctival surface, whether it is scarred or conjunctiva should be always healthy, because at the end of the day we want good bleb which is functional. Grade of the cataract and tunnel size, intraocular pressure, and macular split on perimetry. So visual field parameter VFI is if 0 to 100% and 100% is normal, and if it is 0% it means that patient is having perimetrically blind. So deviation in the shape of the hill of the vision will be measured by PSD, that is pattern standard deviation, and it helps in early diagnosis of glaucoma, and it is very low when it is overall hill of vision is decreased. Then mean deviation, that is mild less than -6, then moderate 6 to 12, and severe if it is more than -12. So various special conditions are, because I have already told that miotic pupil is a major concern, and where we can use the expanders also. Shallow interior chamber, sodium hyaluronate is the need of the hour, and then CCC size at least 5.5 millimeter, good hydrodissection, and lens whatever is the choice. So single site can be done and double site can also be done. Phaco with single and double can be done, but I am discussing only single site. So various type of tunnels are known for this: triangular incision, straight, W-shaped, and flying eagle incisions. So just to show that this is a one case scenario with the 65 years old male, BCV of 3/60, IOP in, on late 20s with 5 drugs, glaucomatous optic atrophy, small pupil, HCV reactive, and then it was planned. And so this is a video which all the steps are almost the same. Here we have to be very careful that we are holding the conjunctiva in a very non-traumatic manner. Then incision the same, but here anterior, that intracorneal part should be a bit longer, because we have to make the slit of 2.2 window. Then another is side port. Again here it is showing that pupil is very small in size despite the best mediatrics. So CCC is same, everything is same, just I'll be skipping and I'll be coming to the main thing. So here the pupil was very small in size, and just a mild of pupillary stretching was done and nucleus got out. So all the steps are same. After putting IOL, then from the side port put pylo, because we need to go into trabeculectomy now. So this is the step where we can make a window of 2 into 2 millimeter with the 15-degree side port or with the Kelly's punch. And then here there is difference that we have to suture the tunnel with 8 type of the suturing, because in the end otherwise on next post-operative day we can get the leaking bleb. So these are the cases, and this is the same case post-operatively and at the 6-month follow-up in the last photo. So after that, we can get very diffusely elevated functional blebs. Then we have a data of 58 cases where all these are the parameters: mean IOP, mean AGMs, disc glucomatous optic atrophy, or it is 0.8 to 0.9, and post-operative complication of first post-operative day, fibrin in the anterior chamber, because we are dealing with the iris also. We are putting so many things for iris. We are dilating, but it is not getting dilated. We are doing PI also. Sometimes we are stretching the pupil also. Hyphema in 3 cases because of the tunnel. It was a bit, suture was very loose. And hypotony in 2 cases and hypertony in 6 cases. For those hypertonic cases, we have done 5 FU, and in some cases, we have done the revision also. So complete success of the trabeculectomy is when IOP is less than 21 millimeter without any AGMs or procedure till 3 months. Partial success if it is less than 21 millimeter with 1 or more AGMs. Post-operative IOP spikes more than 21 millimeter till 1 week, and hypotony will be considered if IOP is less than 5 millimeter of mercury. In all these cases, no MMC was used along with. Failure is persistent hypotony less than 5 millimeter or raised IOP more than 21 millimeter despite best medication. So on literature review, we have got that we are in par with all the study by Rameshwari, Khurana et al. And Verma et al. That our study is having 58 cases with the average baseline IOP of maximum therapy was 40 plus minus 9.3, and mean deviation was minus 21. That is all average studies, and VFI 41, and average AGM 3. And mean IOP at the 6 month of follow-up in all the successful cases was 12. So to conclude, a combined approach to cataract and glaucoma is the option of the choice with poor compliance or difficult follow-ups. Diffuse functional blebs are noted as the incision is larger in size. Intact interior corneal lip is mandatory in these cases, because if premature entry is there, then we have to defer the trabeculectomy. Scleral suturing is must, otherwise we can get the leaky blebs. And meticulous closure of the conjunctiva is also very important. In some cases, if it is charring of the conjunctiva in the end, we suture the conjunctiva also. Post-operative hypotony is the major concern. Thank you.